fix this. Okay. Okay, good morning. We'll call to order the August Board of Health meeting. We have quorum. For the record, there's a copy of the Open Meetings Act on the wall of the legislative chambers, and also there is, I have the official notice of meeting. With that, roll call.
Wade?
Here.
Festerson? McNally?
Here.
Rogers?
Here.
Weiss? Jones? Wilkin?
Here.
King? Espinoza?
We'll go to item 2.
Okay.
Item 2, which is approval of the minutes of the July meeting. Is there a motion to approve those minutes? There's a motion by Wade. Is there a second? Somewhere. Second by Wilkin. Roll call.
Wilkin?
Yes.
Wade?
Yes.
Rogers?
Yes.
Jones? McNally? Espinoza?
Okay, we go to item 3, and we have items A through G. It said on the email that I wanted E and F removed. I can't recall that, but to just cover it, we will include them and go from there. So is there a motion to approve items A through G? There's a motion by Wilkins. Is there a second? Second by Wade. Any questions from anyone? With none, roll call.
Okay. McNally?
Yes.
Rogers?
Yes.
Wilkin?
Yes.
Jones? Espinoza? Wade?
Yes.
Okay.
Okay. We'll now go to presentations, and item A is the CHI Annual Health Community Benefit Update. And Ashley. Morning.
Okay, there you go. And then it's just from one page to the next.
Okay. Excellent. Thank you, Heather. Good morning.
Good morning.
It's a pleasure to be here again, providing an annual community benefit update on behalf of CHI Health. I'm, of course, Ashley Carroll, Market Director of Healthy Communities and Population Health. And I'd also like to acknowledge I have a colleague in the room too, Edna DeSouza. If you haven't met her on the Healthy Communities team, now's your opportunity. And I expect that you'll be seeing more of her in the future. Okay, so quick recap, a roadmap for how we're going to spend our time together. I want to give you an update on our evolving community health priorities, because this update comes at the time in which we're kind of between cycles. We've just concluded a 3-year plan. We've done a needs assessment, so I'll be giving you an update on policies, practices, programs, and partnerships we're involved in and leading to drive community health improvement on priorities previously identified by the community in the prior community health needs assessment, as well as some prospective strategies in the newly adopted needs assessment. And then give you also a community benefit financial update, and hopefully provide ample opportunity for you to ask questions. As you all know, or likely know by now, CHI Health is part of Common Spirit Health, one of the regional healthcare system that operates in 24 states. And here in the Omaha Metro, we have 5 major hospitals: CHI Health Emmanuel, CUMC Bergen Mercy Hospital, Lakeside, Midlands, Mercy Council Bluffs on the Iowa side. We also have a specialty hospital, Nebraska Spine Hospital, that's located within Emmanuel Hospital. We have Lasting Hope Recovery Center, which is a freestanding behavioral health facility. We have a freestanding emergency department on 24th and Cumming Street, and specialty clinics, primary and specialty clinics, over 20 in the Omaha Metro. So just to give you a look at our footprint. All not-for-profit hospitals, as required by the Patient Protection and Affordable Care Act, are required to work with our local public health departments to assess the drivers of poor and disparate health outcomes in our communities every 3 years. Like I said, here in the Omaha Metro, we just completed and published a needs assessment at the conclusion of 2024 and started to really promote that in the community in 2025. Our board adopted or approved our needs assessment in June, and then I'll be presenting our 2026 through 2028 Community Health Improvement Plan to our CHI Health Board in October. I won't describe the major findings from the Community Health Needs Assessment because others have done so masterfully in their presentations to the Board of Health, but I did want to recap the methodology for gathering community input and assessing health needs more broadly, right? So we contracted with professional research consultants to do primary data collection through a population level survey. 3,600 Omaha residents, Omaha and Council Bluffs residents responded to that population level survey. 118 key informants responded to a survey request, and then there was a robust collection of secondary data that was analyzed and synthesized to derive community health priorities. For CHI Health, we thought that was a great process, but we wanted to enhance our understanding of community health drivers at an individual and neighborhood level. So we commissioned the Creighton University Institute for Population Health to host 7 listening sessions in community spaces throughout North and South Omaha, responding to previous and I think justified community criticism that many community members didn't feel as though their lived experience was reflected in the needs assessment data, right? That population level survey has over 100 questions on it, and it calls homes landlines, and We've developed other methodologies to help folks better engage in the process, but this was another way in which we could engage community members, and we did so with 186 individuals that participated in listening sessions that were facilitated in English, Spanish, and Conjabal that helped us derive our new community health improvement priorities for 2026 and 2028, which I'll describe further on this next slide. So let me orient you to this busy slide. On the right-hand side, I've included from the PRC Community Health Needs Assessment Report that each of our health systems jointly commission and fund. Those on the right-hand side are community prioritized health needs. On the left-hand side were CHI Health Omaha Metro Hospital's 2023 through 25 priorities, and then in the middle are our 2026 through 2028 priorities. Hopefully what you see here is one, a response to many of the community health priorities that our community members have said are priorities for action and resourcing. And these are cross-cutting strategies that will allow us to take a life course approach and address multiple health priorities or needs concurrently, right? So addressing behavioral health, we're looking at focused populations within these broad health categories. So there's overlap and synergy with maternal, focusing on maternal mental health is also a behavioral health strategy. That just gives you an example of how these things are cross-cutting. I'm gonna skip this for the sake of time. One of the ways in which we are responding to community health priorities is through our grant making. And this is a new addition since I was here last presenting an update to you all. So our Community Health Improvement Grant Program allows us to invest directly in community solutions. In the Omaha Metro, we have an open request for proposals now through September 12th, and we are prioritizing proposals from community-based nonprofits that address health-related social needs, including access to care and transportation. Those are our greatest priorities in our next grant cycle. To give you an idea of the impact of our investing, in 2024, we made $437,000 in investments in the community-based nonprofits whose logos you see on the bottom of this slide. Their proposals ranged focus areas around access to care, maternal and child health, behavioral health, food, housing, and violence. And we know that we're not experts in all of these things, so it behooves us to work strategically in investing the capacity of these organizations to deliver services and use their expertise most appropriately. I also, before I get into our community health improvement plan priorities, want to make mention as well that each of our hospitals have completed the American Hospital Association Health Equity Transformation Assessment. So this is some of the internal work that we're doing. We've designated a health equity liaison for each of our hospitals, and we've created action plans that align with our community health improvement plans to achieve health equity across 3 major pillars. And that's our people, or our workforce, our patients, and our community. So there's great synergy between these health equity action plans and community health improvement plans, and we've created those in tandem so that it's not just a separate thing, but that it's really embedded throughout the planning and execution of our strategies. Behavioral health. Most of these community health priorities I've outlined in the following way. I won't obviously speak aloud to all of these things, but I've organized these around policy actions we're involved in, practice and programs and partnerships, and so I'm just going to call out a few of these things. With regard to practice changes, we are continuing to integrate primary care and behavioral health services, most recently through our Emmanuel Family Health Center, right? So you can come in, see your primary care provider. You will, if you are experiencing symptoms indicative of depression and anxiety, we've got a behavioral health provider right there at that time of care that can support your behavioral health needs. And then the long-term goal, right, is that your behavioral health is continued to be managed in primary care after you've got your medication managed properly. Additionally, we are piloting and scaling innovative practice models like our behavioral health peer supports. We currently employ 7 across CHI Health Emmanuel, Lasting Hope, and Mercy Council Bluffs. With regard to chronic disease, which was a new priority for our 2026 through 28 implementation plan cycle, I said I've organized most of the slides around policy, practice, programs, and partnerships, but this one, I wanted to give you the way that we're conceptualizing addressing chronic disease, and that's from a prevention standpoint, detection, and management and treatment. So once more, I won't go through all of these. A couple of things I want to highlight for your awareness. We are supporting the diabetes prevention program at One World Community Health Center. It had recently lost some funding, and that'll be a key partnership moving forward. We also are leveraging insights from our universal social needs screening that we're doing within our hospitals to better understand the social drivers of health that impact our patients' ability to prevent chronic disease from developing and managing that condition once they already have the disease. So a couple of things that we're doing include expanding our care transitions program and hiring 2 post-acute community health workers. They'll actually visit patients in their home. They can do, fall risk assessments, and they can continue to manage once a patient, they were screened in the hospital, a social need was addressed, say food insecurity, right? They can continue to provide some case management for those patients after they've been discharged from the hospital to ensure, did you get enrolled in Meals on Wheels or supplemental nutrition assistance if you qualify. With regard to health-related social needs, and just to provide a little bit of distinction, right? Social determinants of health are experienced at the community level. Those are community level factors. Health-related social needs are experienced at the individual or patient level. So that's the distinction that we're making here. We have been involved in collaborative efforts to define CHW's scope of practice and create a credentialing path for CHWs, because we do believe that they're such a core member of an interdisciplinary care team. We have rolled out universal hospital-based social needs screening, and I've got some data to share with you on that. And we're continuing to grow our health and social care resource navigation and health education teams, including but not limited to community health workers and doulas, which I'll provide some more information as well to you on. So this is a look at our health-related social needs screening performance dashboard. We rolled out universal screening for all adult patients in April 2024. They're all adult patients who are eligible for screening, who have capacity to be screened, are screened within 24 hours of admission. And consistently, the top health-related social needs identified through screening are food insecurity, transportation, and housing. This is a snapshot at 2024 data, where the health-related social need positivity rate was 16%, any one of the health needs. But that number is increasing. I pulled data from January through May 2025, and the health-related social need positivity rate has increased to 18%. So I mentioned one of the key strategies to address patients' health-related social needs are investing in a robust community health worker workforce. Currently, we have 6 clinic and virtual community health workers who are addressing patients' health-related social needs and helping to coordinate care across 20-plus clinics in the Omaha Metro. That team received just about 4,000 referrals in fiscal year 2025. They identified 5,500 barriers in that patient pool, and they provided more than 10,000 interventions to those patients. The top 3 needs that they address in our program are financial assistance, health insurance enrollment, and transportation. Another important health-related social need is housing and homelessness. We continue to be involved in a medical respite 1115 waiver to CMS, which would allow 2 medical respite programs in Omaha and Lincoln to be able to bill Medicaid for covered services. We were also instrumental in helping to start the first medical respite program in the Omaha Metro with a $500,000 investment that was given to Santa Francis and Charles Drew to start the medical respite program, which is a community-based program, so all of the health systems can refer their patients there. We're also, at the practice level, we're working with Reimagine, which is a relatively new community-based nonprofit that employs individuals with lived experience expertise to transform systems based on their lived experience with experiencing homelessness. And so they're developing and providing trauma-informed care training for frontline staff and providers, not exclusive to healthcare, based on their experience. And we made a multi-year funding commitment to Heal Omaha, over $300,000 to expand their street outreach program and to provide a consistent flow of medical student and medical providers and staff volunteers. Next, I'll quickly describe maternal and child health. From a little p policy level, we have implemented doula-friendly hospital policies across all of our birthing hospitals in Nebraska, including Omaha. We did advocate successfully for extending Medicaid postpartum coverage to 1 year after delivery, and we continue to advocate for Medicaid reimbursement of doula services. We are screening for depression and anxiety at 3 intervals in the perinatal journey, so at least once in prenatal care within 12 hours of delivery, and then also in the postpartum period. We're also working with IBBG, formerly IB Black Girl, on developing an equitable maternity care continuing education training for providers and staff in partnership with the Creighton University Office of Continuing Education. Really excited. There's many programs and partnerships that I won't have sufficient time to describe, but some of that information is also included in the packet that I provided to you. But a couple of things that I do want to call out. We have enrolled, we've matched 52 patients in the last few years. The priority here is on equitable birth outcomes. So we've matched 52 Black or African American mothers with a racially concordant doula. And with a new grant award, we plan to enroll an additional 150 patients in the Empowering Community Doula program over the next 3 years. And what's really exciting also is that we are working with A Mother's Love and IBBG on this program. But I was floored with the enthusiasm and support of our community-based doulas who were excited to complete city training so that they are now citizen doula researchers and can be part of the clinical research team when we publish our findings. Yeah, thanks for sharing that excitement. I won't talk about Pathways Community Hub. I think many of you know about it, and it's included in your slides so that you can reference those later. Violence prevention and intervention. Again, at the policy level, we continue to advocate for healthcare workplace violence prevention protections that support a safe healthcare environment and that also protects providers, staff, and our patients and visitors. We've offered counseling on access to lethal means and mental health first aid training. We'll begin distributing gun lock boxes and trigger locks and lockable pill vials in our clinics and emergency departments, which has already started in Lincoln. This is a small pilot that we hope will continue to grow. And we launched a hospital-based violence intervention program with U-Turn for patients impacted by violent traumas. They're there in our hospital and they can start that process of a healing journey by receiving wraparound support services, such as employment, education assistance, grief, etc. And we're launching the SAFE clinic for patients who are cared for by our forensic nursing program. Those are survivors of sexual assault, domestic violence, and human trafficking. We're launching a SAFE outpatient clinic for integrated ongoing healthcare needs beyond that initial trauma. Workforce development is paramount to our success in continuing to provide high quality, accessible healthcare. And so we are advocating for nursing scholarships and tuition reimbursement programs to reduce the barriers to entry into a prosperous and fulfilling healthcare career. Some of the programs and partnerships we've set up are featured here, such as our CNA scholarship program for students who are interested in a healthcare career. We certified 68 students as nursing assistants in one program year, and we're developing a surgical tech and anesthesia tech program as well. We've also got teen volunteer hospital programs and health professions medical academy partnerships with several of our local high schools, a couple of which are detailed on this slide. And while the image is a little bit hard to see and she's covered by a mask, but Celine leads this program and is featured in each of these images. She's doing an amazing job. Won't talk about employee volunteerism. Again, you'll have this in the slides so that you can reference that later, but we take it to heart, right? That caring for our communities does not happen just in our hospitals and clinics. All right, I want to give you now a quick community benefit financial update. So for fiscal year 2024, for what we call our Upper Central region, that includes 28 hospitals, about 200 clinics in Nebraska, Iowa, North Dakota, and Minnesota. We provided $240.8 million in total community benefit in our communities. And you say, that's nice, but what about here? So this is the slide that will be more interesting to you. Our CHI Health Omaha hospitals and clinics provided $101.8 million in total community benefit in FY24. That's out of a total of $212 million in total community benefit provided across Nebraska and Iowa. You can see the largest share of our community benefit is medical financial assistance, which includes our financial assistance that we extend to 27,700 patients who were uninsured or underinsured, as well as the unpaid cost of Medicaid. And we served over 142,000 patients who received healthcare coverage through Medicaid. And then just about $30.5 million in broader community health investments, which are detailed a little bit further on this slide. So this is a 3-year trend looking at our CHI Health Omaha hospitals and clinics community benefit from 2024 to 2023 and 2022. So the bottom line number is total community benefit. The top line number is our total financial assistance, which I said are those two pieces, financial assistance and unpaid cost of Medicaid. In FY24, that was $71.3 million. Our total broader community health was $30.5 million. The largest component or single driver of our broader community health is health professions education. That includes graduate medical education, that includes nursing scholarships, precepting, residents, students, techs, et cetera. We also provide $1.6 million in community health improvement services. That's Medicaid counseling and enrollment. That's support groups, outreach things like Stop the Bleed, mass casualty training, financial and in-kind contributions. That includes our grant making in our community, also time that our hospital executives spend on nonprofit boards, for example, or time that they're volunteering on community time or on company time. And then community benefit operations includes the Healthy Communities team. We are solely charged with executing community benefit work. So that's our team's salary and benefits. This year was, we had more expenses in community benefit operations because that also includes the cost of conducting community health needs assessments and health improvement plans, which all of our hospitals do at the same time. I'm not going to spend time on the 5-year trend, but you do have this provided, as well as the numbers are one thing, right? But I also want to give you quantify the number of patients that are served through financial assistance and also covered by Medicaid. All right, that was a lot of information. Do we have time, and does anyone have questions?
No, we have time. Questions? Go.
Hi.
Hey there.
How are you?
I'm doing well, thanks.
Good. I just have a couple questions. The first one's out of curiosity. Once the pregnant mothers or birthing people are screened for anxiety and depression, like what happens after that?
Yeah. So it is a quick assessment. They do the PHQ-2, PHQ-9. They'll do a brief counseling right there in the clinic setting, and then they'll refer them to behavioral health. And then we have some programs so that if finances are a barrier, we also have a program where patients can access mental health care on an ongoing basis free of charge. So we continue to fundraise and get dollars to support that as well.
And does the doula or the community health worker follow up with the patients to make sure that they get those services?
Yeah. And often it's like mutually reinforcing, right? So we have established a protocol on the clinic side that we're screening at these 3 defined intervals, but all our community-based community health workers, like through the Pathways Community Hub, and our community-based doulas that we're partnering with through A Mother's Love, they have their own screening workflow. So there's like multiple folks who are asking mom or that birthing person about their mental health and can know who to call and are documenting that in a shared space so that we all have line of sight.
Okay, thank you.
Yeah.
And then my next question is, how do you determine where the community benefit dollars are allocated? Like do you have buckets that are destined before, or does it just kind of happen?
Are you talking about like our community health improvement grant making, or like the detailed broader community health
in general,
categories?
the community benefit dollars. So when you showed the one slide
Yeah.
with the different buckets, I think most of it was for medical care that they couldn't afford to pay for, unpaid medical.
Yeah.
So that's what I want to know, like how are those dollars allocated in terms of like, are they preset before the year starts, or do you just do it as the year goes on?
Yeah. So the areas that I have the least influence on are financial assistance and unpaid cost of Medicaid, right? We don't have a dedicated bucket of funding to extend financial assistance. It's just our policy that if a patient comes into our hospital and requires financial assistance, they're afforded that. There's not a shut-off valve at any time. And what we've seen is a modest increase in our financial assistance because more patients are coming in who qualify for financial assistance. And our payer mix is heavily government payer sponsored. And then in the unpaid cost of Medicaid, that too is largely outside of our control, both in who's covered under Medicaid, though we do have a team that helps assess folks' eligibility for Medicaid and other health insurance programs and helps get them enrolled in those programs. But we can't control necessarily what those government payers are going to reimburse us commensurate with our costs. With regard to the broader community health, that too, I don't have a fixed budget for each of these items, right? So community health improvement services are largely reflective of what are we already doing, things like, that we would do without a mandate to provide reporting on this. We don't have a dedicated budget, but we've made a commitment to providing basic life-saving support skills training, right? Something like that, or Stop the Bleed. We get requests and we provide that service. There's not a dedicated line item for that. Where I do have a budget is in financial and in-kind contributions. Our community health improvement grant program, I do have a dedicated budget. We provide about $1.2 million across our Upper Central region in grants each year.
Okay. I was just curious if the community health improvement plan somehow kind of helps to determine where the benefit dollars are allocated to.
It helps, that is the filter that we use to prioritize requests, right? But yeah, that is the filter that we use. And I would say too, we also try to align, there are other buckets of funding that our health system has to support community health improvement, such as corporate sponsorships, for example, right? That aren't necessarily a community benefit, but we say these are the organizations that are addressing community prioritized health needs, and so this is where we should prioritize our corporate sponsorship dollars too. Yeah, yeah, thank you for the questions.
Couple questions about
It's a little bit hard.
couple questions about
Okay,
the community benefit. Significant decrease in research from drop to 18. Could you identify what's going on in terms of that trend being so significantly less? And then overall, this disappointing trend in community benefits starting from 2022. What do you think are the major drivers?
Yeah. I'm glad you pointed out research because that stood out to me too. I don't actually think it's a reflection of a diminished investment in research. We know writ large community benefit is underreported. It's just really hard to track, collate, and report all of the things that qualify as community benefit per the IRS, right? And we have a lot of churn in healthcare, so some of that institutional knowledge about the things that do count as community benefit gets lost. So we've been doubling down on staff education and training for folks who are engaged in all of these activities so that we do have complete and accurate data on our community benefit investments. We've also provided some clarity to staff recently. We've always taken a judicious or prudent approach to our community benefit, but in particular in research, we use the Catholic Health Association's Guide for Reporting Community Benefit, and it's pretty clear. Research that advances generalizable knowledge is largely what meets the definition of research that can be counted as community benefit, such that you have costs that exceeded any revenue that you received, right? So I got a grant to conduct this research. Well, if there was costs that exceeded the amount of the grant that you received, that generally is, we need more details to qualify. That's generally what would get reported here in this research line item. And so, yeah, we're an academic health system. We know there's a lot of research going on, but I think folks have just been very prudent or reluctant to report research activities. And so we're trying to, this is one area in which we're diving more deeply into. And again, healthcare is a high churn industry. And so we have to continue to train and educate and re-educate folks on what counts as community benefit. And then with the decline in community benefit overall in this multi-year look, again, much of that has been driven, the area that I have greater influence over is broader community health. And modestly, we've been increasing our investments in our community in those areas. In the medical financial assistance, the decline is largely attributable to increased reimbursement in Medicaid, which is outside of my control. And it's holding these two things, right? Two things can be true at the same time. When we expect that this number will continue to go down, right, with the state-directed payment programs providing greater reimbursement, more reflective of the true cost of providing that health care. But it also means that we can continue, that we are getting reimbursement commensurate with cost so that we can continue to reinvest in our facilities and in our workforce and driving community health improvement in other areas. So that's the story I would tell regarding the trend. I do anticipate that next year when I come back, that unpaid cost of Medicaid will continue to shrink even further, and it's not exclusive to CHI Health, right? That'll be across the health systems.
Before you go to explain that, Ashley, explain the part of how the uncompensated Medicaid would go down. Are you
Yes,
saying-
right, because we'll be
direct payment?
receiving greater reimbursement, right, through the state-directed payment program. So with LB 1087,
Okay,
we applied to CMS
Okay.
to implement a provider assessment. So we're assessing ourselves a tax that allows us to draw down federal reimbursement on Medicaid covered health services.
I thought that got removed in this last bill, or does it not kick in?
In the One Big Beautiful bill?
Yeah.
It'll be stepped down. So this is like our trend lines are going to be wonky, right? It was approved by CMS. We started to book 6 months of revenue in fiscal year 25. CMS has approved the first year of the program.
Mm-hmm.
In the One Big Beautiful bill, we are grandfathered in because we had our CMS waiver approved by the time the bill was enacted.
Mm-hmm.
So we are still moving forward pending CMS renews our application to continue the program. But beginning in 2028, that's when it starts to titrate, and then it will decrease the cap on the provider assessment annually each year until it's commensurate with Medicare. So we'll see this, so it's got an inverse relationship, right? We'll see enhanced Medicaid reimbursement from the federal government, which will mean we'll get more reimbursement and our unpaid cost of Medicaid, or that shortfall, will go down. But then in 2028, we won't be eligible for as much enhancement, and we know that Medicare too lags in truly compensating us for the cost of providing that care. So
Okay.
you'll kind of see these topsy-turvy trend lines.
Sorry, Dr. Joe. I just wanted to follow.
Ashley, thank you. You guys are very busy at CHI doing amazing things, so thank you
Appreciate that.
for the update. I'm just curious how you're deciding with these two post-acute community health workers that you're implementing for the discharges. Like, how do you decide who gets the home visit and that kind of thing?
Yeah, great question. Because you're right, there's going to be a lot greater need than 2 community health workers on the post-acute side can support, but we had to start somewhere. So the pilot the eligibility criteria is patients from our Omaha Metro hospitals. They have to have either a diagnosis, the eligibility criteria includes diagnosis of either heart disease, which is one of the conditions that we see overrepresented in our readmissions. So heart disease or, heart disease. I'm getting the medically tailored meals one and the care transitions programs confused. So 2 eligibility criteria, heart disease and an identified health-related social need. Doesn't have to be food insecurity, that's the top one, but it can be any one of those that will make a patient eligible for enrollment in the care transitions program. And we're just gonna have to monitor what that CHW caseload looks like, how many patients. There are likely to be a lot of patients who will be eligible, but who might decline service at the time of care, right? And so we'll have to continue to manage capacity and then hopefully make the case for expanding.
Awesome, thank you.
Yeah.
And then as far as like the workload, I mean, it sounds like with 6 community health workers doing over nearly 4,000 referrals, it seems like a lot. Is that typical for a community health worker?
Well, I don't know that it's typical, and I wouldn't want to reflect on the community health worker workforce writ large. It is a medical model, so I think that they can support a greater caseload because the community link team is not going into patients' home. So they're providing shorter interventions, right? Some of the things that are listed on the slide: providing a resource, a brief education and information sharing. They participate on coordinated calls, right? So patients eligible for Social Security or supplemental nutrition assistance, they'll actually sit on a call, with DHHS, because oftentimes patients find it challenging to work through that application process, even when they're eligible for services. So those are the kinds of things that they're doing. And then we are actually involved in a mixed methods evaluation of the program, which includes a cost-benefit analysis or a return on investment to make the case that they're doing amazing work and they're serving a lot of patients. Imagine what we could do with a larger workforce.
And a patient can get more than one referral, right? So that's why that
Yes.
so that's why that number is higher, because
Right.
it's not just one referral per patient. It could be 5, 6 referrals for that one patient, depending on what the issues are.
And that's typical, right?
Yeah.
Most patients that are referred to the program have more than one need.
Okay. Yeah, it just seems like it's a time-consuming process a lot
Absolutely.
of times with the work that they're doing. So I'm just astonished that that's a lot of referrals that they're making and handling. And lastly, for the chronic disease prioritized area you guys are doing, so it sounded like prediabetes I heard, but what are the other chronic diseases that you guys will be focusing on?
Cancer, heart disease, diabetes, hypertension are some of them. We will not be touching on all of the areas in which CHI Health has specialty services, right? This is really in terms of being targeted towards the areas where there are demonstrable disparities in our community, or the community has elevated this as a priority. And this work too, the chronic disease pillar of this work is in that prospective category. So technically, it's been prioritized and our health system leadership has signed off on these priorities, but the plan, including those strategies and tactics related to chronic disease, hasn't gone to our board yet for approval, but I wanted to give you guys a preview of what's upcoming. Yeah.
Anybody else? Okay, Ashley, go back to, you went early in the slide, that slide that had 2023 to 25, 2024, then it had 2020.
The financial data?
No, it's the,
Oh, the priorities? Sorry for the scroll.
keep coming. It had 3 columns.
Yep, our priorities, I think, maybe, you can correct me if I'm wrong. We're getting there, I
Yeah.
promise.
No, it's up there, it's up there.
This one?
Yes. So, okay, just help me, because this is how I understood it. So, the one we just did
Yeah,
is 2026, 28. We got this 3-year, we did the one this year.
right,
That one was done in 24,
Yeah.
and that's going to take the 3-year period of 25 to 27.
here's where it gets a little confusing.
Yeah, that's
Right.
why I'm clear that up.
We
That's
all
what I'm
have
saying with
slightly
that.
different cycles and timelines.
Okay.
So there's the community health improvement plan, which is reflective of the health departments taking the key
Which all
findings
you
from
all
the needs
participate
assessment,
in.
developing a plan, and then the hospitals develop their own implementation strategies or community health improvement plans. And
Yeah.
each of the hospitals are about 6 months variance in their timelines.
Yeah.
So the PRC completed the needs assessment and delivered a report at the end of 2024.
Right.
And that's the priorities that are shown on the right side of this slide. Does that
Okay.
answer your question?
So,
So for us, it happened in FY 25 is when our needs assessment.
Your 24 is leaning into this year. Your 24 slide is leaning into the current one, or is it the last year of the past?
Super confusing, I know this. I had to develop this mental shortcut for me. So our fiscal year is the year in which our cycle ended, right? We run on a July 1 through June 30 fiscal year. So fiscal year, it's 2023 through 2025. So technically our last 3-year plan just ended June 30th, 2025 this summer.
Okay.
So we are now kicking off a new 3-year plan, which is the 2026 through 2028 plan. But the IRS says you have 6 months after your needs assessment was board approved to have your board also review and approve and adopt your new implementation plan. So we're technically in this new cycle, but the way that the board schedule works, I don't get on their schedule until October. But we're doing a lot of this work already, because a lot of this is legacy strategies.
Your 26, 28 priorities is using the plan to just complete it.
Correct, yes.
Okay, that's right, okay. So then, take me then, everyone's got a question, but not the slide. Explain to me how the gun lock thing works. How do you all end up giving out a gun lock? Somebody walks in, and from the assessment, they say they got a gun, and you offer them, or how do you end up giving that out?
Yeah. We are approaching this very sensitively and cautiously.
Okay.
Because this is something that a lot of our providers said, I'm uncomfortable having this conversation. So we're not talking about universal screening. We're not asking every patient when you come in, do you have a gun in your home and is it safely stored? This would be risk-based screening, and it's going to come after additional provider education and training. Our providers have told us this is a polarizing, like very sensitive topic. They tell me stories about patients like walking out and saying like, that is not your business. Like, don't ask me about that. We're not recording it in the electronic medical record. That's another misnomer that some patients have. This is simply about providing safety. And so we've partnered with U-Turn. We receive a grant. This summer, we gave U-Turn some lock boxes and trigger locks that they could distribute at a community event in June, a Wear Orange gun violence prevention event. But eventually, like in the case of Lincoln, the health department, Lincoln Lancaster, did receive funding to purchase gun lock boxes trigger locks and lockable pill vials. And our clinics in Lincoln and our emergency department are distribution sites. So it's more about, we're providing some environmental cues like signage and brochures so that patients might be tuned in that I might get asked about this, or this is a conversation I could have, and then we'll be providing them at the patient's suggestion. If it comes up, like I see you have this brochure, or do you guys have lock boxes? And we say, yes, we have a lock box. If you'd like one, you can pick it up at the reception. But we're not currently distributing them because, again, we want to work with our partners. Children's Nebraska has been a great resource to us too in this effort, because they have been involved in some of this work in the past, and so we want to learn from their example and go slowly so that we can do this methodically and effectively.
So you're using a third party, basically.
Currently, but the goal will be, as it is in Lincoln, to be a distribution site, an access point for gun safety devices.
Okay. So lastly, then go to the slide you've been working off of with the other questions that has like the before you go to that, the 3 divided pie that has uncompensated care.
And we go to
that always
financials.
at the end, almost before questions, because I want to ask you about the black and white slide that you had, like the budget line. Just go to that one. That's the one I got a question on.
You got it.
Right before the question slide. Okay. So, I'm assuming. Explain to me, because the way I thought I understood this, but the way you explained to me, I must have got mixed up. Explain to me the top line of the financial assistance and the unpaid cost of Medicaid, because I always thought that the financial assistance line would balance off the unpaid cost of Medicaid or something like that. I guess just explain how you all go about those lines. I'm assuming financial assistance is a direct money hit. Is the unpaid cost of Medicaid something you're just counting and writing off and counting on the books? How does that work? Because for some reason I had this thought like Medicaid, let's just say Medicaid, it costs $1. Medicaid pays 60 cents. And my thought is community benefit would balance that out. And I'm thinking that that's not it. So I'm just trying to explain help me understand how that financial assistance and that
Sure.
2 Medicaid lines work toward community benefit.
Yeah. Okay. I'll do my best. And you can
Nope,
tell me if I
I
answered
just-
the question.
I'm in
or
a
not.
range, and then I can ask questions outside.
Okay, so financial assistance is care that we've provided on a sliding fee scale
Okay.
to patients who are uninsured
Okay.
or underinsured, but they still qualify for a subsidy. Unpaid cost of Medicaid is what you're describing, right? It's that if it costs us $1 and we get reimbursed at 40 cents on that dollar, that 60 cents is essentially a write-off. We can't recoup that through other means, and so that is the unpaid cost of Medicaid, which is we are one of the largest provider of Medicaid covered health services.
So it is coming out of community benefit, but it's a separate thing of, the unpaid line is straight for Medicaid, the cash balance that out. The first line is people could be covered, they're not fully covered, and you balance out based on the sliding fee.
Right, or they have no insurance at all,
Okay,
and they maybe don't, and they don't qualify for Medicaid.
okay. And so then for the last question, financial and in-kind, you were saying that your budget for that is 1.2? Okay,
That's one of the subcategories in that financial and
Yeah.
in-kind contributions.
so your hard cash is 1.2, the other stuff is contribution. Is that the line at the
Community health
400
improvement grants.
Yeah, the 437,000.
Yeah. Mhm.
Okay. All right. Okay. Now I would say I like how your report feels, because your report feels like the money is actually going out and not getting recycled into the organization to come back. So I just, that's the piece I definitely like about y'all's plan.
Appreciate that.
And I might have it from a later point, but I'd like you all to note this, because I'm gonna guess I need to talk to you about the Medicaid piece.
Yeah.
Because my question is, now, with this grandfather piece in, it seems like the ramifications of this won't happen for a couple of years, because my point to ask up and eventually ask is that, are you thinking if there's no changes made to that bill, and in 28, 27, things start coming back, that unpaid Medicaid line is going to grow more, and will that take money out of the discretionary stuff you all are doing? And can I anticipate, is that a foresight that we need to be looking at and having some discussion about? Because you're thinking it's rural hospitals, but
Yeah.
I'm thinking it's going to be an urban effect too. Eventually, when this bill goes into effect and you get out of the grandfather phase, do you kind of get the question I'm asking?
I think so. And so I didn't include on this slide, but we could spend a whole another hour talking about the headwinds before us, right? The One Big Beautiful Bill has wide, sweeping negative implications for healthcare and for folks' ability to access healthcare. So what I anticipate when it's fully implemented, right? We know that 10 million Americans will lose Medicaid coverage over the next, or over 10 years when the bill is fully implemented. So I think we'll see an increase in our financial assistance as folks lose Medicaid coverage at a time too where we're going to see diminished reimbursement for folks who are receiving health coverage through Medicaid. So both of those will be negative impacts for patients in our communities, and will strain our ability to remain fiscally solvent and provide same level of service and community benefits.
Yeah, I'd be interested in your just projection on how that is, because I'm assuming you all and UNMC will hit more than Methodist, but I'm gonna ask all y'all the same question, so I just putting it out there. So okay.
We're doing that modeling, and it's on the list of things that keep me up at night, for
Okay.
sure.
All right.
Dr.
Appreciate
King,
it.
did you have a question you looked like you were going to? Okay.
Thank you, guys. Appreciate it.
Thank you for the opportunity.
All right. We'll go to item B, which is the corn sweat extreme heat tabletop. Next.
Good morning, everybody.
Morning.
I'm excited to have Jack here. I don't think you've met Jack. Jack is Jack Gordon, one of our new ERCs. I would say he's an up-and-coming public health rock star. He's been doing really, really well. But today he's going to talk about our tabletop exercise, Corn Sweat, which I know Councilman Festerson was kind of interested in, so I'm sure he's upset not to be here, even though I think he's somewhere better, vacationing right now. Just a couple of quick things about this tabletop exercise. This was part of a competitive grant that we applied for. We actually had to develop a tabletop exercise and submit it to NOAA and the CDC. I think there were only 6 grants, is that right? 10 winners. And Douglas County Health Department was one of them. So it was a small amount of money. It was about $20,000, but that was enough to allow us to bring a lot of people together, which Jack will talk about, from all sorts of sectors, from energy, hospitals, schools, etc. But this work really aligns with kind of the Sherwood grant that we applied for and received for emergency preparedness and working our way into kind of the extreme weather events, global warming, things like that. So without further ado, I'm going to turn it over to Jack, and we'll be happy to answer any questions.
Thank you, Justin. And thank you, everyone. This is my first Board of Health meeting, so I appreciate the opportunity. As Justin mentioned, this was a challenge that was put out by the NIHHIS, the National Integrated Heat Health Information System. That's a joint effort between the CDC, the National Weather Service, and we were one of the 10 winners across the nation. That was issued. The challenge was issued to emergency management, state, local, tribal health departments, and all of that. So to be one of the 10 winners was a great opportunity for us. I would like to mention that Caleb Cudis, my predecessor, the former ERC, was the one that led the charge on that, and he brought together people from the National Weather Service, OPPD, Salvation Army, and UNMC to draft that scenario to make it as realistic and accurate as possible. The goal was to stress our local capabilities and identify what strengths we have and what areas could use some improvement. There were over 60 participants. From the government section, there was local health departments, also Lincoln, Lancaster Health Department, and Sarpy County were able to show up. Omaha Metro Transit was there, general assistance. We had our partners from the state, the Nebraska Emergency Management Agency, were in attendance to help with the exercise. Millard Public Schools, National Weather Service, and Omaha Fire Department. Another number of NGOs and community-based organizations like the Salvation Army and Red Cross, and we also invited the Stevens Center, Threshold COC, and Together, who are focused on unhoused services. We wanted to make sure that we brought in representation for the people that would be serving those communities into this as well. Healthcare, we had Methodist Health System, UNMC, Nebraska Med, the Healthcare Coalition that sort of oversees a lot of their work, and then a number of ambulatory surgery centers. And then, of course, MUD and OPPD are utilities. Excuse me. So for the scenario, it was an extreme heat scenario with estimated temperatures up to 120 degrees and overnight temperatures that would stay above 85 degrees. So even though it is cooler at night, it was still a dangerous temperature for those who would not have access to air conditioning and those vulnerable populations. The exercise was split up into 2 modules. The first module was the pre-storm. So there was high temperatures and vulnerable populations are at risk, but a lot of the organizations are focusing on internal communications, how they would equip their employees and how they would prepare for an event like this. And then we would introduce an inject, which was the storm that came through, and that storm was another variable to kind of test our capabilities. So that would cause debris, that would stress the capacity of healthcare facilities, as well as there was a power outage in northern Douglas County in this scenario. And so then the second module of the scenario, they would be focusing more on how they would respond to that storm and how they would continue operations. As they worked through the modules, after the first module, we had everybody split up into different tables. When they were completed with walking through the scenario, each table would brief out to everybody else in the room to discuss the way that they would address it. And that would give it an opportunity to give everybody in the room a little bit more perspective and also a little bit of crosstalk between the people. Very quickly, there were some strengths that were identified. There was some strong communication across agencies using social media, email, websites, a variety of platforms, going so far as even being able to knock on doors. Salvation Army talked about their work doing that to make sure that they're able to reach those communities if for people who maybe didn't have power and needed to hear that firsthand. There's a lot of effective coordination for opening cooling centers. I think that that's something that our county does exceptionally well. And Threshold COC has been a leader in that. Every time that we need to get information out, as the Douglas County Health Department, they're my first go-to to figure out what cooling centers and shelters are available, and we get that information out to the public. A lot of community partnership and healthcare facilities were successfully able to identify their plans and actions to continue operations. Along with strengths come some gaps and areas for improvement. We noticed that there was not a lead for public messaging. I think that every agency that was in attendance was able to discuss the way that they would reach out to the public, but I don't think it was as coordinated as it could have been. Cooling center information is a little bit delayed. In order to collect information about which cooling centers and shelters are open, it's a very manual process. It involves calling back and forth to collect all of that. So that's something I'd love to see a little bit of work on. Transportation, EMS, and Metro Transit discussed their methods of transporting people to those cooling centers and shelters. But if they were overwhelmed, there isn't a current plan in place right now, and that is also something I'd like to see addressed as well. The next steps, in my after action report in my after action report and improvement plan that is currently in the works right now, it's pending approval. We've identified all of these gaps and areas for improvement. We have identified potential solutions, and then we've also identified lead agencies. So I can only speak for Douglas County Health Department and the work that we plan to do, but we would love to be able to follow up with those agencies that we think would be best to lead that approach, identify any existing efforts and tools that may already be in place. There may be people that are already working on some of these projects as well. And then we'd like to facilitate a collaborative planning environment for those folks to be able to actually implement those plans. There was overwhelmingly positive feedback from all of the attendees, and I was very proud of this. They talked about potentially developing this into an extreme cold event as well to compare and contrast what those response efforts would be, and then maybe even building this up into a full-scale exercise to see what that would look like as well. So, are there any questions that I can answer? Yeah. Corn sweat? That was Caleb. Caleb came up with it himself. That's are you familiar with corn sweat? The idea is so. The closer you are to corn, yes, they produce so much humidity and warmth. When you're close to a cornfield, the temperature I think raises up to like 5 to 10 degrees warmer than the rest of the city. We've got a corn sweat expert.
Yeah, no, I'm not at all. But if you step outside, you'd feel like it. But I did want to mention this was a 2-day event. So the first day we partnered with experts from the College of Public Health, the National Weather Service, and they actually came in and provided a whole day of education prior to the actual tabletop exercise. We had a lot of really great comments back, feedback from folks, and a lot of the organizations of the 60 people that attended are very interested in us doing something related to cold weather, extreme cold as well. So really great event. But if you have any more questions, I'll let Jack answer those.
Yes, yep. I anticipated to be ready by the end of the month. Yep.
So you identified the things that still needed to be figured out, or is that part of the after action report, like what the suggested solutions would be then?
Absolutely. Attached to that after action report is an improvement plan.
Okay.
Yep. With the identified areas for improvement, the potential solutions. I think it's important to identify what needs to be fixed, but also figure out how we can do it. And then also the suggested lead agencies that would be best suited to lead that effort. I got off easy. Thank you very much.
Good morning. A few updates from the department over the past month. Our mosquito surveillance has been ongoing, and we're very happy to report that so far this year we have not identified any West Nile virus, Jamestown Canyon virus, or any other vector-borne diseases to be concerned about. I know that there have been some identified in other places, but so far our mosquito populations have been mostly clean. So we're good on that front, but of course we'll continue to do that surveillance as needed. We were also notified that we will be receiving full OD2A funding this year for I believe it's year 3. There had been some question earlier in the year whether that full funding was going to come through. I think I heard maybe half of the funding, and so we were kind of bracing for the worst. However, we were notified that that is going to come through fully for us, so we're very happy to be able to continue our OD2A work. And just for a refresher, that is our overdose fatality review team and the work that we're doing toward overdose prevention in the community. So we're very excited about that. We have been working toward formalizing an academic practice partnership with the College of Public Health at UNMC, and just wanted to let you know that we are pretty close to actually having that formalized, and so we'll make sure to come to you when that is fully complete and give you details about what that's going to look like. But essentially, this is an effort for us to assure that we are able to integrate students in public health and research in public health into the department, and then also the department assisting the College of Public Health, working on workforce development and education and things like that. So it's a great partnership that's worked really great in a number of jurisdictions, and so we're really excited to have that work coming to fruition hopefully soon. A quick update on our lead team. Our lead team has been pounding the pavement pretty hard and also pounding the virtual pavement pretty hard. They have developed a Stop Lead website for the community to go to learn more about lead poisoning prevention. And over the past couple of months, they have built out some social media messaging, and we were really excited to hear that so far over 22,000 impressions on our website and over 56,000 views on social media for that. So great job to our lead team that continues to get that education out to the public. I wanted to also mention that our fetal infant mortality review team has been doing really fantastic work and has just been able to maintain some great energy around pushing forward with that team, with the case review team. Our goal for this year was to get at least 10 maternal interviews. Just for context, it can be very difficult to get those interviews with bereaved families following the loss of an infant. And so getting those interviews can be pretty challenging. We have done 9 so far, and we have 10 and 11 scheduled. So I think we're going to blow past our goal of 10. And I'm really proud of the work that this FEMUR team has done to keep that energy moving and to keep the energy going in the community. And I think it's a real testament to our FEMUR nurses' ability to really do what she does with deep compassion and empathy in that she's able to get this many interviews with these families. So good job to our FEMUR team. A quick update on the Community Health Improvement Plan. It came up during Ashley Carroll's presentation just a little bit ago, and you saw how they have set their priorities already. Ours are in progress, so we actually will be meeting this afternoon with the Regional Health Council and the Wellbeing Partners to talk about that process and essentially continue that process on. And I did want to mention to you that we recognize that everybody is kind of on this different time schedule for when we're putting out priorities, and there wasn't really a good way to synchronize that this time around, but that is an expectation that we have asked for with the Wellbeing Partners, is that as we go into our next iteration of the community health assessment and then the subsequent chip, that we are actually taking into account all of the different timelines that are out there and hopefully syncing them as closely as we possibly can so that we can actually synergize the release of information and the release of those priorities to the community so that we're all kind of moving together in lockstep. We haven't had the opportunity. I'm sorry?
Picking up trash?
I'm sorry, I think someone's come off mute.
Can you mute? Yeah.
Okay,
There you go.
we're good. Environmental health team is working hard today. And so I just wanted to let you know that we have a timeline of late this fall for the community health improvement plan on the public health side to be complete. So we'll be coming to you with that in coming months. I also wanted to let you know something that we've talked about kind of over the past, it seems like, long time, but especially over the last year, building out our performance management program and really the structure for how and the framework for how that is actually going to work officially within the department. We really had a lot of scaffolding to build around that, and I'm very happy to report that we did finish training our management team on the system that we will be using, and they've actually started playing a bit with goal setting and putting that into our new performance management system. So we'll be taking that to all of our staff here very shortly and are hoping to have our goal setting complete later this fall as well. So that has been something that we've been working on for quite some time. There was a whole lot to do in order to really build that framework effectively so that it'll work in a way that is sustainable for everybody. So I'm also very excited to report that. I also wanted to give you just a quick update on the foundation as requested in some previous meetings. We are moving forward with that. We were able to work, I think that perhaps Elizabeth and Chris might have let the county board know about the retaining of an outside law firm to do this work, which was what was recommended. It's just in statute that we have to go ahead and let them know about that. So we have a letter of engagement that's already complete. And then we are working on naming it. We have to work with the health center, who also has a foundation, to make sure that our foundation names aren't too close together. So we're working on that. And then the attorneys that we're working with at Baird and Home are also assisting us currently with just starting to put together the articles of incorporation, which will then go to the state. And then it's a waiting game to see how long it takes for that to be returned. And then from there, we're able to apply federally for that nonprofit status. And so those are the upcoming steps. We're working behind the scenes to get everything set up in terms of the work with the state. So that's just a quick update on where we are with that. And I would love to tell you when that'll be done with the state, but unfortunately, it's a little bit difficult to predict that. So I will keep you updated, but unfortunately right now I don't have a timeline on that piece. And that, I think, is it for updates. Do you have any questions that I can answer today? All right.
God, I lost the question I was going to have. Let me lead in a little bit into 4 while you're there. No, 6 while you're there in the department and the report updates. I guess my only question to you, and it could be out here too, are you all? What is the chatter with all of the vaccination cancelings happening nationally? What are you seeing ahead of time? Because just in reading through that and some of the vaccination reports, I mean, what's the chatter? What are we, I guess, preparing for? I'm just curious on what's out there and what are you all anticipating on that?
Yeah, we're keeping our ear to the ground on that, and I have not heard anything solid from DHHS in terms of vaccine that's coming down, other than I know that we have I think, received less VFC dollars over the past year than previously. So, of course, that impacts our ability to provide vaccine to uninsured children. But right now, I'm waiting to hear more. We're waiting to hear more from DHHS in terms of what that's going to look like. Unfortunately, I don't have details for you yet that are anything confirmed, so I will certainly keep you updated on that. And of course, the hope is that, you know, the impact isn't going to be as great. Of course, if federally, ACIP, CDC don't recommend certain things, that makes it very difficult for us to get that VFC funding for, you know, for the vaccines for children if recommendations change from ACIP and CDC. So it is a very messy situation right now. And of course, going into school, that's not a great place to be, but we are hopeful that we are going to be able to maintain. I do believe that I read earlier this week that they are planning to still recommend the flu vaccine. But other than that, I'm kind of up in the air unless Leah has heard anything different. No.
So schools supposed to get their vaccines now. And I'm assuming this, I don't know what the deadline is. I think no. When kids are going to checkups, they're recommended for the vaccine.
Right.
Do the doctors send that to the state and then the state sends that back down to you as the county? So you know what the county is? How does
No.
that flow happen?
So there is actually not a statute or a mandate for physicians to report vaccinations into the state. And so what happens is that the schools require the documentation from the parents for vaccine status when they come into school. And so we actually get reporting from our school systems on basically the vaccination status of our children. So there is vaccine data in the state system. It's just probably not complete if not all physicians are reporting into that system, which isn't, it's too bad because it would be great to have that true number, but we're kind of doing a workaround where we're able to get that information from our schools.
But so the last time, I think Justin mentioned something last time about the numbers being down. Will you, October, November, you will think is a reasonable time to know for enough time in schools to report? Because I'm curious to see how this trend is coming down for them getting vaccinated.
Yes, I would say October is reasonable in terms of when the schools would have all of their waivers in and all of their vaccine records in and those things. I'm not sure how quickly it will come down from the state. So we can request that information from the state and from our schools. It may take a little bit longer to actually collate all of that data together in a way that's mostly complete for you. But I would say it's probably by October they're going to know. The school systems are going to know probably what their vaccine rates look like. And I think Justin has something he wants to add.
Well, yeah. That data comes out annually and is usually a year behind. So it's going to be difficult for us to know the immediate impact. But I did see that ACIP made recommendations for children regarding COVID vaccine, and the American Academy of Pediatrics is now separated.
Repeat on the record again, what's the ACIP?
So it's the immunization group that RFK kind of dismantled and put back together. And so this is the first time, I think, ever that the American Academy of Pediatrics has taken a different position than the ACIP on vaccination related to kids. So I think we'll see more of that, and it'll be interesting to kind of see how that affects things like insurance, repayment things. So, yeah.
Historically, they have, yeah.
So vaccination is going to be interesting. We'll see what happens in the next
You saying
year.
it won't be covered?
Then
that'll be for the local departments to kind of help make up the gap with.
Say
Is that
again.
fair? If it won't be covered, then that's going to be for the counties, locals to make up the gap on how do you get kids covered.
Well, that's just it. Typically, you bill for vaccines, and that's kind of how, if you have private stock, if you're billing for vaccines that you're giving, you're able to replenish your stock through basically the revenue that you get through those that insurance billing. But if insurance starts to not cover it and parents want it, it's really going to probably come down to private pay, unfortunately. At the health department, we only have VFC. We have no private stock. We historically have not had the funding to actually order private stock to keep on hand. And so what we are watching is really what's going to happen with VFC and whether we're going to be able to get vaccine through that to offer to families whose insurance doesn't cover that vaccine. So it's messy, and unfortunately, we don't know right now whether insurance companies are going to choose to continue to cover based on the ACIP recommendations, or if they decide, hey, we prefer the American Academy of Pediatrics recommendations, so we're going to cover those. We just don't know yet.
Okay, so based on what Justin said about this being a year behind, this is the point I need you all to keep an eye on, because I need you all to give the board enough data to, if there's anything, I guess, to use the bully pulpit on, it's this. So I just need you all to keep us alert on that enough, because that's something that probably press-wise you need to be screaming, saying,
Yeah.
we're used to relatively decent vaccination rates around here, and if insurance is not going to cover it, I think that's something that we just need to be raising up and putting there. So if we got a year lag, I need you all to keep abreast of that so we can think through how to put that out there.
Yeah, absolutely. And there's room to likely work with the school districts to get some of that data, sooner than later. I don't know how perfect that data would be, but we would want to probably work with the state as we're doing that and make sure that they understand where we are with that, as data sharing has been a little bit of an issue at times. And so we want to do our due diligence with them as a partner just to make sure that they know that we would be asking for that. But you are absolutely right. This is not a time to be working with old data. If we're able to find something more recent, or if we're able to work with our districts to potentially gather that more quickly than, a year behind, that would be ideal.
Okay. If nobody has questions on those reports, I think I do need to have a executive session real quick with the board just for personnel. We won't be taking any action when we come back, so if there's no need for anybody to wait around. And this will be quick. So with that, is there a motion to go into executive session for personnel, and then we'll just return and after executive session and adjourn. This motion by Wilkins, a second. Second, King. Roll call.
Who seconded? Weiss?
King.
Oh, gotcha. Sorry about that. Okay, we have Weiss? Espinoza? McNally?
Yes.
Jones? King? Rogers?
Yes.
Wilkin? Wade?
Yes.
Okay.
All right. Thank you.
Bye.